And by the way, I'm not the only one that thinks that. Everyone that I've ever worked with has thought the same thing.
Yeah.
But it is what it is. Yeah. Hello, everyone. Welcome to yet another episode of Eclipse Unscripted. I am Dr. Leake, a pain management specialist. And with us today, again, we have Keith.
Yes.
From Invisibles No More.
Visible No More.
Very good. Welcome.
I'm glad to be here. This is a great opportunity.
Yes.
I'm really blessed to be able to sit down and talk with you about all these topics.
Absolutely. Of course, our goal is to enlighten the common chronic pain patient, educate them, provide them with some tools to find the doctor that can help you, help yourself, and hopefully live more with less pain.
So I see the purpose here today is for our chronic a pain doctor to understand what a lot of us chronic pain patients actually do and how we live outside the 10 minutes you get to see us once a month.
And, it's hard to learn a lot about somebody in 10 minutes every month, but absolutely.
It is.
So yes, thank you again for taking the time. I'm here to learn. And today we have an interesting topic, specifically as it deals with alcoholism and being a chronic pain patient.
And it's a topic I'm anxious to talk about. And I'm anxious to learn as well. I get it from one side, but since you're dual certified or whatever, and pain as well as recovery, I really want to get your opinion and your thoughts on the subject.
Sure. And for the audience, I'll clear that up. So I am double board certified in physical medicine and rehabilitation and pain management. I did study addiction medicine, of course, throughout my training, and specifically worked at a clinic for opioid addiction for a couple of years, actually. So I'm very familiar with the topic, although I'm not board certified in it, just to keep that straight. But yes, obviously we see a lot of pain patients that deal with additional or other addictions, including alcoholism is, quite prevalent and something that needs to be addressed.
It does. So what do you do if somebody comes in and we've discussed before that I feel you have to be open and honest. You have to have an open, honest foundation with your doctor.
Right.
If you really want to get better, there's no secrets, there's no things to hide. And if you have been battling alcoholism or addiction, is that something that I'm wanting to tell you from the moment I walk in? Because I'm afraid that my level of care may be drastically different than somebody who doesn't.
Right. Well, obviously, you're going to be asked about it. There's no doubt about that, probably in a couple different ways with regard to not only your entire medical history, but just specifically alcoholism. So I do want to know about it. And even on that first visit, now you may be coming from a place where you don't feel like you can be open, or you might be feeling judged out of the gate. And I would hope, at least if you were coming here, that you would feel disarmed. And I would tell you it's very important to be very honest in that regard. I
don't disagree with you on that. By the way. I don't. I'm not trying to tell people to lie when they come in.
Never lie to your doctor or your lawyer.
That's it.
They're here to help you. Yeah.
But I'm just trying to put myself in their shoes.
Sure.
So that's all that's the only reason I asked that question.
And I think probably the reason why you're asking that question is because of the stigma that is around alcoholism, let's say, in this case. And the fear might be that either you're going to be looked at as lesser, or your plan of care may be somewhat dismissed because you're just someone with an alcohol problem, or perhaps, you won't have access to certain medications such as opioids. Right.
That's it. And part of what we do with Invisible is to let people know they're seen, they're heard, they're loved, and they're not alone.
Right.
And so I get people that reach out to me.
Yeah.
And that are alcoholics, and they're like clean for 3 years or so, and they're like, all they will offer me is like gabapentin. And while I'm grateful to get some help with it, it's not a whole lot. And so I'm stuck. I can't get any care. Right. And I hate saying that because again, it goes back to people being humans. And is there something, what can be done? Because while they are telling you that they've had issues in the past, they've been either clean, sober for 2, 3, 4 years. They've proven that they're not doing what they were doing. But there's still, it feels like the stigma's carried over, and they're not afforded other treatment options.
Right. Yeah. So that's, definitely worth talking about. And, I think obviously the stigma is around the risk of overdose. Right. So, we know that, patients that have died from overdose, opioid overdose, let's say 1 in 5 of them have had alcohol in their system. The other risk is, let's say, combining opioids with benzodiazepine, Xanax, Valium, things of that nature. Those medications hit the same receptors that alcohol does. So also that is, tended to definitely argued against. Don't combine those two medications. And you won't often see, one pain doctor prescribing both unless there's a very specific reason and a very specific patient. But alcohol, there's really no medical indication for that even. So while you can make the argument that, well, this patient has uncontrolled anxiety, they take a low dose Xanax every now and then, perhaps it's safe in this particular scenario. And I'm, again, not saying that's true across the board, but hypothetically speaking, okay, there's a medical indication. However, there's no medical indication to drink alcohol. So it's very common to have, you mentioned pain contract earlier, when there's an agreement between the physician and the patient as far as what the expectations will be for taking opioids, alcohol is always included in that as being excluded from the plan of care. And so that is one of the things we're looking for too on the drug screen, because it's not that we don't want you to have a good time or feel like you can't go out drinking with your buds. It's really just, if you combine that with this drug, the chance of you overdosing is at least twice as high.
And it's not like an intentional situation either. It's if you are drinking and you take your pain meds, you're not thinking about, oh, I'm going to overdose on, I'm not. You're
not thinking about it, yeah.
Until it's almost too late and everything gets amplified and multiplied in your system. And I don't think that's, for those cases, that's intentional, but I understand why it's in the contract, right?
Sure.
And I would think for a lot of people that alcohol, especially if you have neuropathy, alcohol is the last thing you want to put in your body, because it will fire. It can, in some people, fire those nerves up if you have neuropathy, to where it's just excruciating.
Oh, absolutely.
Because alcohol is a toxin.
Right.
So like if somebody comes to you and they're doing the right thing, I've got 4 years clean. My current regimen is 600 milligrams of gabapentin every 3 hours.
Right.
And I'm still, my feet and my legs are still just killing me. Is there anything we could do?
Absolutely.
Could contracts be written for that person? Again, it goes back to individualized care, right?
Right.
To where it's like a closely monitored situation. I'm not saying specifically for you, I'm just talking in general. Would that be something that a patient could offer to a pain doctor or to a PCP? I feel as a chronic pain patient, I need to be willing to do whatever it takes to get better. And we've talked in other times about how we have to be active in our care and our plan, right? So if a doctor said, all right, I'll give you some pain meds, but you'll be in here every 7 days. I'll write you a script for 7 days, and we're going to test you.
Right.
And you have to know, it's not because I don't love you. It's not because I don't believe you're in pain. It's not, but these are the regulations. These are my personal rules.
It's for your protection.
For your protection too, that I need to be able to show everybody that we're doing this in a protective and on a monitored way.
Yes.
This isn't about me making more money by having you come in. This is about making sure everybody is safe in this situation. Yeah,
and if you're coming in every week, you're probably overbooking for that patient anyway. So it would be even harder on the business, but individualized to that patient, because we do care. We should care, for individuals. In my pain contract, it doesn't have an exclusion for a history of alcoholism. It has a warning against combining alcohol in real time. And of course, that is part of our education anyway, and we test for that in our drug screens. But I would say, if you have a history of alcoholism, you're going to be treated just as any other patient that may be a candidate for opioids. And based on the answers we're understanding, the risk profile of that individual patient, you're going to have higher risk patients than other patients. And that'll dictate, and in combination with what exactly their prescription is and how high risk the prescription is and all these things, right? There's multiple factors involved. But the higher the risk the patient, the closer the monitoring. That's just the rule of thumb. The lower the risk of monitoring, of the patient, the lower monitoring. Now, there's always monitoring. There's always going to be random. There's always a minimum, and that I think minimum will differ from physician to physician, clinic to clinic, state to state, right? But there's some physicians out there that argue, well, I test every patient every single time, because if you truly have an addiction, because the idea is that it's a random drug screen, you don't know when you're going to get tested, and so if you do it every time, then what's to stop that patient from just preparing for it every time? But the argument is that a truly addicted patient can't even do that. Their life is so disorganized that you're going to catch them. So, the bottom line is the higher the risk, the closer the monitoring. Now, if you have an active alcohol issue where you can't control how much you drink, you need it to live, the last thing I want to do in that case is add an opioid.
Right.
And I don't think anybody would disagree with me there.
Yeah, I don't think I could argue that point.
Yeah.
If somebody's active in any addiction, a drug or an alcohol,
right,
I don't think they should be given. That's a no-go, unfortunately, because I want them to get better, but sometimes maybe prioritizing which better first. Yeah, and then we can address it. And it's been a while since I read my pain contract. I need to go do it. I think since I've lived a little bit of a distance from you, I think when I signed it, I don't know if it's in it, but I even gave you permission on randoms to tell me to go to the local, I'm not going to give them any advertising, but the local testing clinic. Yeah. You have the rest till the end of the day to get there. Sure. And that I take that serious. Yeah. And not that I'm not doing anything off the books, but I'm willing. Again, I think that goes to show as a patient, what I need to be ready to do, because I need my quality of life. Mm-hmm. Right. And right now, opioids are helping me get that quality of life. Mm-hmm. Now, the ketamine and the gabapentin is starting to help more too. Mm-hmm. So the idea is the more of those, if I get stable on that, then we can drop the opioids down. That's the hope, right? Yeah. That's my hope. But I have to be willing to, okay, I guess I'm going to go to the clinic up the street and go pee in a cup. Sure. It's not a big deal. Right. I like hearing your say on it though, because it gives me hope that other doctors will start doing the same thing. Mm-hmm. Because I've known people who can't get seen at all because it's in their insurance has it in their file that they were in a treatment center. So there is no getting around it. Mm-hmm. Right. And even though they have years clean, there are doctors that are just hands off. Right. Because they don't want to. But I think that goes maybe back to the fact that there's only 2,400 of you in the States. Right. And each and every one of you is way overworked. And unfortunately, doctors are going to have to pick and choose. And I think it's a sad situation, right? Because I hate seeing anybody suffer in pain. When we have the tools, I think that's a whole other.
No, I mean, that's the whole thing. And eventually you're going to get capped. And not to say every patient's on opioid therapy, but you can only see so many patients. And so then for most physicians and clinics, that puts you in a position to be a little bit more selective, making a decision for the company, right? Well, it's like, okay, we can only stretch ourselves so far. Why bring on liability unnecessarily? And that's the sad reality. And, but it is a reality nonetheless. That's not to say you can't find somebody that won't help you. You can. I mean, it's a big country. But you may have to move for it. You may have to drive for it, but yeah, no, I think if you're immediately, suffering from, alcoholism and you can't control and you're in that state, you need to get help. And that's going to be your first big step, even towards pain management, quite frankly. And then you will find that a lot of doors will open up for you after that. It should.
In theory.
But we have a patient that maybe didn't experience that today.
Yeah. Mark is battling it. He can't get any kind of help besides the gabapentin.
Mr. Producer, let's see if we have a message here from Mark.
Good morning, Keith in Texas. My name is Mark, aka Lugnut. I wanted to start this video. This is my first time, so please go easy on me. I was an alcoholic for roughly 34 years. Started very young and continued on through. For a few years, I was just a normal kid drinking. And then it became progressively worse over the last 20 years. It was involving beer and hard alcohol. Last 5 years, it was a liter of vodka every single day and night. I started having chronic pain about 2 years before I quit drinking. I was still drinking very, very, very heavily. So I started traveling about an hour and a half away to a neurologist. Sometimes 2 times a week, sometimes every week, going up for MRIs and different tests that they would run. I was diagnosed, I've been sober for 3 years and almost 11 months. And that's just about the time I received my diagnosis is when I quit. Polyneuropathy. I only have about 10% feeling in either my feet or legs, and that's moved into my arms and hands. Thoracic myelopathy, which causes pain around the middle of my back, my sternum area. Degenerative disc, of course, and arthritis throughout my body. I tried working the last year, the first year I became sober, and I was taking 24 Advil a day to get through my job, and I've always been I grew up Gen X, I grew up on a farm. I've always been a very, very hard worker. And that carried through most of my life. So the wear and tear I put on my body can explain some of the back issues. But the main thing that caused most of my problems physically is the alcohol. They call it chemically related thoracic myelopathy and neuropathy and everything like that. So to try to cut to the chase of what you're looking for, the stigma. I wanna focus on the stigma that comes with addiction, and there's really not much difference in the addiction community between drugs or alcohol, pills or alcohol, or heroin or alcohol. It's all pretty much the same. An addict is an addict. Now, I never had a problem with pills or hard drugs. It was all alcohol. But through these pain diagnoses, once and even at my neurologist, once that record comes through, and I do have a medical record because of going and getting help for my addiction. That's all documented. Even my neurologist went right to the fact with, "Oh, you were an addict, you were a drinker. Well, this explains everything then." Kind of a one size fits all. Been to a couple pain doctors. Walk in, they look at my record, and they say, "There's nothing I can do for you. We can't help you." Now, my PCP, who I get along with very well, but he just refuses to even look at that aspect of it. I'm on. I needed to. To me, it all comes together: addiction, chronic pain, and mental health. My mental health suffers because of my pain. My pain suffers because of my addiction. And it's a vicious circle. So.
Thank you. Wow. So he did all the right steps and got clean. And 2 pain doctors said, "Sorry, bud, there's nothing we can do for you." Yeah. Maybe they can't do something. I'm not saying I can do something.
Right.
But I do want to put this out there for any potential patients watching this, is that there's always something. There's always something. And we may not know what the answer is today. But there's a lot of things to try. And it sounds like those pain doctors that said no to him, maybe they're like orthopedics with a hammer. Everything's a hammer. Everything's an opioid. Sorry, you're not a good candidate.
And maybe, you know, maybe they're not thinking outside the box enough, right?
Right. Or they're not set up to.
Yeah.
Not to their personal detriment, but they're maybe just not set up to.
Yeah. But Mark is just one of the people I hear from.
Yeah.
And unfortunately for Mark, his ability to travel is pretty much non-existent due to where he lives and the pain that he has. An hour and a half each way to a bigger city where there's more doctors is not an option for him. And I don't know how to help, because he's tried to monitor me, and he's still getting the flat. And I think it's that stigma that he's fighting, even though he filmed that it was 3 years, 11 months, so it's over 4 years now. He's stayed clean and sober. It's not just dry. He's actually active in his recovery, and he's doing all the good stuff.
Yeah.
Right. He's still not able to get anything more than probably gabapentin is all it's on. You know? So I think it goes. That's why I don't condone lying, because you can't have a good care plan if you lie.
Mm-hmm.
And I don't want people lying, especially when it comes to this, because I don't want an accidental overdose. I don't want people.
Well, chances are we're going to find out anyway.
Yeah.
We'll request your old medical records. We want to know, have you had problems in the past? I mean, that's all part of the job description. So definitely lying is not going to help you out.
No. Temporarily, maybe.
Yeah, maybe temporarily, but then it's going to come back. Yeah.
Yeah. So I just don't know, how can we as a community, working with good doctors, help start to turn the stigma? Because as a community, Invisible has been really good at changing some mindsets in certain areas, like going from, we've had people with atrocious histories with nerve stimulators, but who used to tell people to never do this, don't ever get one. And now they're telling people, if you want to try it, if you think it'll work and it works for you, I'm celebrating that.
Yeah. Right.
So are there any ways that we can try to reach these doctors, hospitals, insurance companies even, and say, oh, okay. Glad you have good eyes. 'cause
Yeah.
I didn't
Jeez.
catch it.
Well, I can see I'm paying attention to my my scopes over there. There we go.
Oof, that's
Yep.
brighter.
You're
Shouldn't have
back.
looked up.
So you're celebrating it.
So we're celebrating people finding, even though it doesn't work for us, we're celebrating it working for somebody else.
Mm-hmm.
So is there a way that we can approach doctors or PAs or nurses or ER doctors and with, I've battled with alcohol, or I've battled
Right.
this addiction,
Right.
but I've documented that I'm good. I'm
Right.
better. I'm active, getting better. Help.
Yeah.
Yeah. Is there a way how do I word that? Or help somebody who's going to see a new doctor. How do I help them? I guess this is selfish. How do I help them word it to where maybe a doctor might be more receptive? I'm afraid they're going to get a buzzsaw anyway. They're going to get a negative anyway, but
Sure.
the answer is always no.
Yeah.
Unless you ask.
Yeah.
Right.
No, obviously, I mean, I have no power in even dictating how other doctors work by any stretch, right? So all I can do is speak for myself in this regard. And I would say that when I'm flipping through medical records, if I'm deciding if a patient wants to come here and I'm looking at their chart, if I want to take them on as a patient, because a lot of times patients will doctor shop, and they'll
It's not
mess
doctor
around.
shopping. Well, there is doctor shopping. Time out. There is doctor shopping.
Sure.
Where people go and they try to get meds from.
There's
as
a
many
good
doctors
reason to
as they
doctor
can.
shop, and you should.
It's not. No, the good reason is called interviewing doctors.
Interviewing doctors. So
Or-
doctor
or
shopping.
getting a second opinion.
Yes, and you should.
So that's not doctor shopping.
So let's redefine the word. No, I agree.
I'm sorry, I'm a stickler on that.
No.
but-
I mean, I'm a stickler on addiction and dependence. So,
Okay.
So, what I'm trying to say is that there are patients that don't follow the plan of care,
Right.
get discharged, and then they move around to become somebody else's problem. Right. So
Okay.
that's what I'm screening
That's
against.
doctor shopping.
That's
Okay.
doctor shopping. Yes. No, definitely you should be doing second opinions, all of the rest of that. That's not what I mean. But so when I'm reviewing the records, I want to make sure, yes, okay, they're legit patient. They have something that I can help them with. There's no major red flags, right? Now, if I do see alcoholism on that, it will pop out to me as a potential flag.
Right.
But I don't deny just based on that. So if I see that, it will pop out to me. But unless it's active, I'm not making an exclusionary decision just based on that. If it is active, I probably wouldn't be the best person for them, and
Right.
not to discriminate them from my care, but they probably need maybe some inpatient treatment or some intense outpatient psychological intervention to help break that habit first. So that's to their own benefit. But no, I mean, we're looking for those things. But if I see that it's been in the history, you've otherwise been compliant, come on, let's talk. Where are you at? Show me. I would need you to be honest. Obviously, I want to see how you buried that demon. I want to know what the steps were. What were your challenges? What worked? What didn't? The more you can explain that to me, the more you're going to build trust and say, oh, he's got some insight. She's got some insight and experience. That means I can probably, give you a little bit of leeway here, because it's not like you're just hanging out there figuring it out,
And I think that's very fair, that if you see that in somebody's chart, see alcoholism in somebody's chart,
Yeah.
where they've been not active, right? Where they've done treatment or they've done AA, whatever, and they're good for a few years. When they come in, I think as a patient, we need to be able to answer the questions. So what was it that what was your bottom, and how did you turn it around?
Mm-hmm.
I think we need to expect that as a patient. Not because to me, that's not an invasive question. That's a well-guided question that a doctor should ask, right? Mm-hmm. Again, it goes back to, how do we become better patients? Well, you have to face things, right? You have to want to be active in your care. And by answering that question, even though it's difficult, I think we would need to expect that question.
Yeah,
right.
Absolutely.
So,
Sorry.
Friday.
Yeah, it's all right. I'm hurrying.
I appreciate your patience, man. I know this.
Yeah, no.
This frustrates me like no end.
It's all right. It's all right. they're just ready to go home, man.
This is our first podcast in this room, so we're still figuring it all out.
That's all good.
It's coming together. I think it's still better than the other room.
I like the sofa. I like comfortable chairs. So
Yeah.
But no, I like the setup with this, and where you can have the videos on the screen, and it's feeding into that, and then the lighting and I like it a lot. I'm jealous. And like I said, when on the way home, I have to call American Pain and Disability to talk about my podcast after this, so I'm not done talking yet.
Oh,
so
good
I've
for you.
got an hour and a half conversation to have on the way.
But yeah, no, that was a fair question to ask. And so, yeah, it's just, again, I think that's kind of the theme of today is being transparent, being honest with your doctor. That's going to go a long ways. Unfortunately, in Mark's case, it doesn't seem like that's enough. And that may just be a part of the bigger picture and the bigger problem that, a lot of patients are facing in this country that there may not be a good answer for. It may just come down to finding somebody that's, willing to sit down with you and hear your story. And unfortunately, not everybody's in that position.
Yeah, unfortunately, not every doctor is going to be able to. And then it's an unfortunate kind of where we are right now. Mm-hmm. I don't have an answer for Mark, and I don't have an answer for a lot of people who are in his position that can't get care. Mm-hmm. I just try to coach them when they go in, explain what happened. Yeah. They're going to find out. Right. And just be open and honest. And, this is what I battled. This is then, this is where this is where I'm at now. Yeah. You can call the hospital and verify I did my inpatient. You can call my sponsor. You can call whoever you want to call. Yeah. I'm an open book when it comes to this.
Exactly. That builds rapport.
And then suggest, I know you would take a chance if you take me on. What do you want? Weekly monitoring? You want a couple of times? What do you want? Mm-hmm. Because I want to be able to, I want to get better. And I realize that this carries a stigma, whether it's me or it's somebody else. So what can I do? You want to do weekly? You want to do twice weekly? What do I need to do? And offer that in the beginning. And you still may get a buzzsaw doctor that's going to say, sorry, I can't help you.
You may.
But again, if you don't ask, the answer is always going to be no.
And I think to kind of bring it back, it's always important to search for non-opioid treatments too.
Yes.
Right. And gabapentin may be one option, but there's 5, 6, 7, prescription drugs I can think of off the top of my head that could be alternatives. Vitamin supplementation, stimulators, even external stimulators, anything that can help with the pain that's non-opioid. And I think for me, it's important to cover those bases first because a lot of them work. That's number one. Not everything for every patient. Some patients need opioids, but you have to be willing to kind of go through that and be open to, because then it's like you're convincing me I need pain relief, whatever that may be. I'm not necessarily here for a drug, even though you might be. But as part of that communication and trust building, no, we need to be on pain relief. And let's try these first because it's the safest and it has a great chance at working. Yeah. And then if it doesn't, okay, now let's have a different discussion, but we've already built that trust.
And we built the trust, and you'd be able to document in the patient's files. So when the state does come calling to say, hey, we've done X, Y, Z.
Sure.
We've attempted X, Y, Z. And it keeps coming back in the back of my head. A pill is not a plan.
It was not a plan.
A single pill is not a plan.
Right, exactly.
A single pill can help be an important part to a plan. Yeah. But what are we doing on top of that single pill? Are we trying to exercise? Are we trying to walk to check the mail? Yeah. Can we do that? Can we build ourselves up to that? Mm-hmm. Right? Are we trying other things, gabapentin? Or are we just going in and saying, give me this or give me nothing? And it kills me that people will do that and then go home and be in severe pain because they're not willing to try something else.
Yeah. Right. So it's definitely a challenging topic, but I certainly think a relevant one. And, again, it just kind of feeds into the whole discussion, how to be a good patient, how to find a doctor that's willing to work with you, and, using the resources that you have. And there's always going to be stigmas. Everybody's always had stigmas and will always have stigmas. It's just learning how to live with it realize it's not personal. It's not personal. A lot of times these decisions are way above even the doctor. It's just how the business works. It's how the hospital works. It's how the state mandates things. It's impersonal, right? And to give that system the benefit of the doubt, it is in place. At least I haven't fully removed my belief of that it is to help keep people alive and healthy, right? Maybe that's a different discussion. Now, 2016 maybe is a good argument against that, but that's, again, another discussion. But we're not systematically trying to put people into, coming from a lowly doctor's perspective, trying to systematically put people into bad situations. It's, I think, oftentimes maybe not the best response to a tragedy that's occurring. Nobody has all the answers, and it's a very complicated situation. But I guess I'm going down that rabbit hole to say it's not personal. And I feel for those patients that get caught up in that. I wish there was more that we could do.
I wish so too, because there are a lot of really good people that unfortunately are getting lost in the shuffle in this system that we're in.
Yeah.
And I'd do anything to get some people like him better care.
Yeah.
So we'll get there one day.
You may have to move.
I don't want to go to New York.
Yeah, no.
He may have to move. He can come to Texas.
Yeah, come to Texas. If you found this conversation to be helpful, do leave a like and follow, and leave a comment below. What did you jive with? What was maybe not something you agreed with? If you have questions that you thought of during this discussion, leave that down below too. I will respond to them. And please follow Keith on his platforms.
Yep. If you go to TikTok, search Invisible No More, all one word, or even spaces. So it doesn't matter. You'll find us. You'll see our videos showing up. So
Awesome.
You'll find me that way.
All right. Thank you,
Cool.
Keith.
Thanks, sir. We appreciate you.
Until next time.